Good morning. So, in the next 15 minutes, I'll be speaking about wake up stroke. And as you know, that currently the stroke guidelines have been extended, and till now it was like 4.5 hours for acute ischemic stroke with regard to IV thrombolysis, and now we have got an extended window period for treating these patients, both for intravenous thrombolysis and for mechanical thrombectomy. So, we all know that stroke is an emergency, and as soon as a patient develops an acute stroke, it is very important that the patient reaches the hospital on time, so that as early as possible you need to treat these patients so that the patients benefit from the treatment. So, looking at the pathophysiological mechanisms, if you have a patient with a stroke and there is a major vessel occlusion, we know there is a core in which most of the damage has already been done, but there is this penumbra which is very variable in the extension of the penumbra from the core to the penumbra, and this is mostly decided by the leptomeningeal collaterals, and the collaterals not only depend upon the ethnicity or the age alone, but there is also multiple comorbidities. All these are related to the leptomeningeal collaterals, and if you have good collaterals, you are likely to be a slow progressor and your damage is going to be less even at 12 hours or so. So now we have gone from the time window to the tissue window, and in fact it is by advanced imaging we can really know how much of core is there and how much of salvageable penumbra, so that we are able to treat these patients better. So, if you look at all the intravenous thrombolysis and the meta-analysis of all the major thrombolytic trials, we can see that if you see this data, you can see that when it comes to less than 3 hours, the patients have got the maximum benefit with intravenous thrombolysis. But as time extends to more than 4.5 hours, you find that there is a significant less benefit compared to the patients who have been treated within the first 3 hours. And even if you look at the age wise also, as you can see here, if it is less than 80 years versus more than 80 years, as the age is extending to more than 80 years, the benefit even becomes lesser, and you are likely to less benefit if the patient is treated even after 3 hours. So overall, if you look at the intravenous thrombolysis with acute ischemic stroke within the first 3 hours, the favorable outcome will come down with regard to the number needed to treat, and also with regard to the neurological impairment. What we are talking about is an NIHS improvement after treating these patients with acute ischemic stroke with thrombolysis. And you can see that if it is within 3 hours, you find that the number needed to treat is 8. Compared to the patients who are treated in the later window, it increases, the number needed to treat increases. So coming to wake-up stroke, we know that what we call as a wake-up stroke is the patient has got an ischemic stroke and the patient wakes up with the stroke. That means when the patient goes to sleep, the patient is totally normal and the patient wakes up with the symptoms. And this constitutes at least about 1/5 of all ischemic strokes. But it's very important to ask the patient the history with regard to whether it is really a wake-up stroke, so that if the patient has woken up in between becomes very important, and also to know whether at that point of time the patient was totally normal. So that is why, in addition to the onset of time, we always ask about the last seen normal, which becomes very important, because it is presumed that when a patient wakes up with a stroke, most of the stroke happens just before awakening. So that if your patient comes to you, the patient wakes up at 6 o'clock and the patient comes to you at 8 o'clock, the patient is most likely to be still in the window period to treat with IV thrombolysis, compared to a patient who has woken up at 6 o'clock and comes to you at 1 o'clock in the noon. So the concept of the in these wake-up stroke, it's not only in the wake-up stroke or any unwitnessed stroke where the patient, we do not know the time of onset, or in situations where the patient is beyond the 4.5 time window up to 9 hours. Currently the concept is to use the core versus the penumbra mismatch, for which we are all familiar with the rapid software, wherein which we can look at the do a CT perfusion in these patients, look at the core and also the perfusion deficit. And if a patient is having a perfusion deficit, the patient is likely to benefit from the treatment. The most important landmark trial which has come out is the Wake Up trial, wherein they have used the diffusion flare mismatch concept. So why this concept is being used is we know that the flare changes will take at least 4 to 4.5 hours to start. So it is not looking at the perfusion core mismatch, but it is mostly looking at the time window, whether we are within that 4.5 hours to treat these patients. But it is also important, if you are doing a MR based evaluation in these patients, it's always better to look carefully at this image. So this is the uppercuts are the ones where you are seeing a diffusion flare mismatch, where you can see the diffusion is showing the damage, but the flare is not showing any damage. And also if you see here, there is no flare damage, but if you look at the below image, you can see that the diffusion and the flare are showing the changes. But in addition, it's also important to know that there may be very subtle changes in the flare you may see when you adjust your window, but very subtle changes are okay to treat, because that is what they have shown in the Wake Up trial too, that you are very confidently you can treat these patients. And this is from the Wake Up trial. As you can see that, so the Wake Up trial are the patients with no large vessel occlusion. So it's very important to know that, because we know that the late window thrombectomy is already there and we can treat these patients in the later window. But if a patient is not having a large vessel occlusion and the patient is coming with a disabling stroke, and if you treat these patients, they have a diffusion flare mismatch, and if you treat them, there is a significant benefit in treating these patients, and the number needed to treat is only 8. And what is most important when we treat these patients in the later window period, or when we are not sure about the concept, it is important to know that whether the bleed risk is increased in these patients. And you can find that the bleed risk is definitely not increased if you are treating these patients, which is not significant. So recently from the European Stroke Guidelines, the 2021 guidelines have come. So with regard to a patient waking up with stroke, if you have a MR-based protocol and if you see a diffusion flare mismatch and there is no major vessel occlusion, you can safely treat these patients with alteplase, and they are likely to benefit, and the strength of recommendation is strong and the quality of evidence is also high. And also, it is not only for these wake-up stroke patients who are within that time period. So if you have a patient, it is not only that you need to do a diffusion flare mismatch, you can even look at the CT perfusion or a perfusion scan. And if you see that there is a core perfusion mismatch, you can treat these patients with intravenous thrombolysis when they do not have a major vessel occlusion and they are not candidate for mechanical thrombectomy. So following this, the recent data has come out. After the Wake Up trial, we know that the extended window period is still possible in these patients, and there is definitely a group of patients where the core is unlikely to expand and there is likely to be a perfusion deficit which will be still remaining. And this is the systematic review and meta-analysis of all the 3 studies, the Extend, ACAS-4 and the Epithet, where they found that definitely treating these patients with intravenous thrombolysis, if they have a perfusion deficit, they are likely to benefit and the symptomatic bleed risk is going to be less in them, and you can safely treat these patients. So, and this data has actually included at least 50% of these patients in this extended window period are the patients who are wake-up strokes, where you know that when we are taking the last seen normal, definitely they will be having an extend. Most of the time the patient may sleep at 10 o'clock, wake up at 6 o'clock, so there is already a mean time of around 7 to 8 hours wherein the patient can be definitely treated. And more important is that when they looked at the time strata also, up from 4.5 hours to 6 hours versus 6 to 9 hours, these patients equally benefited by intravenous thrombolysis as according to this data, suggesting that up to 9 hours, if there is a mismatch, you can definitely treat these patients. The next main concern was all these data which has come out are all with alteplase, and now TNK is a drug which has been used a lot, and with TNK can we really treat these patients? And this is a timeless trial which has been presented in the European Stroke Conference recently and just published in NEJM. So what they looked at is if a patient is reaching a EVT capable center, in an extended time window, that is in the 4.5 hours later, that 4.5, we know that within 4.5 hours you are going to do bridging treatment for these patients. But if the patient is coming after that window period, can you still bridge these patients? So what they found in that study is that there is no use of bridging in these patients if the patient is reaching a EVT capable center and there is no difference in the outcome. So if a patient is coming to a EVT capable center and the patient is at like 5 hours or 6 hours, it is better to directly take these patients for EVT rather than treating these patients with the bridging. But if you look at the TWIST trial, which is also recently published, so whether we just do a non-contra CT in this patient without any perfusion study, can we still take up these patients? So this study clearly showed that you should not be treating these patients with a non-contra CT alone. You need definitely better imaging information before you treat these patients. And the next data is with regard to, this is an important data which will be most relevant to a country like ours, where in LMIC we know that very few centers are EVT capable. So a patient is coming within the outside the window for IV thrombolysis within the extended window period, and you are in a not an EVT capable center, and is it safe to treat these patients in the extended window period by IV thrombolysis? So this is from the TRACE 3 trial, where they looked at biosimilar TNK versus dual antiplatelets, and they found that from this data, they found that the TNK is definitely better than the placebo in these patients. So if it is in a EVT not capable center, you have a patient with a large vessel occlusion, you are safe in treating these patients. Definitely compared to the placebo, the TNK has got a thrombolysis would be a better option in these patients. And the guideline also brought out that doing a non-contra CT is not enough in these patients when you are treating them. So this is one of a patient who is a 68-year-old with a 5.5 hours from last seen normal, NIH is 7, and you have a very small infarct seen in the diffusion. There is a M2 occlusion and there is a mismatch. You can definitely treat these patients with IV thrombolysis because the distal M2 may not be accessible in most of the centers in our setup. But this is another patient who comes with a 7 hours from last seen normal with a M1 occlusion. So here, if the patient, you want to go for a bridging in these patients with the current data, you can say that patient is 7 hours, patient is in a EVT capable center, it is always better, and there is a diffusion, there is a CT perfusion is showing a mismatch. It is better to go take these patients for direct EVT, or if the patient is not in an EVT capable center, the option would be could still give a trial of thrombolysis for these patients. So who are the candidates for late window thrombolysis? Is patients who are in the 4.5 to 9 hours. If they have distal occlusions, they are good candidates. You should document a diffusion flare mismatch or a perfusion damage, and you see that the infarct should not be a major infarct, it should be a smaller core in these patients. And the evidence base also shows that with regard to TNK, we are waiting for more evidence, but alteplase, there is enough and more evidence. In this area, we may need more evidence to give TNK, but we know that TNK is non-inferior to alteplase in most of the data which is available. And coming to the late window thrombectomy, we know that this is one of the most important breakthrough treatment in the management of acute ischemic stroke. A patient is coming up to 24 hours. You can safely treat these patients with thrombectomy. If a patient is coming as a wake-up or within the 24 hours time period or an unwitnessed stroke, they can be very well treated, and the number needed to treat is only 2.6 in these patients. So this is a patient with coming at 12.5 hours from last seen normal, who woke up from sleep. Aspects is very good, and this patient has got a major vessel occlusion, and there is a perfusion deficit, and this patient was treated directly with endovascular, and the patient benefited from the treatment, and the MRS was 0 in this patient. So from the diffuse and the dawn, we clearly know that if the patient is reaching a EVT capable center, whether it's a wake-up or an unwitnessed stroke, these patients definitely benefit from treatment with regard to giving the mechanical thrombectomy for these patients. And both the dawn and the diffuse trial has shown the same data. You can either go for a clinical imaging mismatch. What we mean by looking at the clinical deficit and looking at the imaging mismatch, or you can go for a perfusion damage by either by a CT or an MR perfusion you can look for, and if there is a mismatch, you can treat these patients in the later window period. So the best algorithm we can follow is that if your patient have a suspected stroke, less than 4.5 hours, you don't have any doubt. There is no major vessel occlusion, you go for IV thrombolysis. If the patient has got an LVO, it is best to bridge the patient. Now the evidence is more for bridging and then taking up for EVT. And if you go for more than 4.5 hours, you know that CT angio, and it's better to do a perfusion study. If there is no LVO, there is a mismatch, you can still treat the patient up to 9 hours. And if the patient has got an LVO and there is a mismatch, please treat the patient with mechanical thrombectomy. Thank you.